Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Pfizer.
This program is presented by Medscape Education Global.
Hello, I'm Robert Gottlieb, a professor at the TCU School of Medicine in Fort Worth, Texas, and a cardiologist at Baylor Scott & White Health in Dallas. Welcome to this program entitled COVID-19 Antivirals, Real-World Evidence Review. I'm very pleased to be joined today by Dr. Luke Moore, an honorary clinical senior lecturer at Imperial College London and a consultant in infectious disease, microbiology, and virology at the Chelsea and Westminster NHS Foundation Trust. Welcome, Luke.
Thank you, Robert. Great to be here.
So this program, we're going to start by providing a brief overview of the ongoing clinical burden of COVID-19 and the current clinical treatment landscape. We will then review the latest real-world data on COVID-19 antivirals before discussing the implications of these findings for clinical practice. So let's get started. Luke, can you tell us about where we are with COVID-19 now and update us on the current clinical landscape?
Thanks very much, Robert. And welcome to you all. So we're in a completely different situation now than we were back in 2020, 2021, where we had a significant number of COVID patients, but that number of COVID patients affected essentially the entire global population. And there was one predominating lineage at that time. Fast forward to now, 2025, and what we're seeing is a very different epidemiological scenario. We're seeing, yes, COVID traversing through our citizens across the different cohorts which we serve, healthy youngsters, children, older individuals, but what we're seeing is a differential impact on those different citizen cohorts. When you overlay on that human heterogeneity of COVID-19, what we're also seeing is a virological heterogeneity. As you would expect from a coronavirus, it has mutated, it has changed in its transmissibility and its vaccine escape. But what we're seeing as we move through all of this is different elements of our population are differently impacted. For some citizens, COVID-19 is still causing death. And when we look at the WHO data feeding through about this, what we see is, for example, in the last month, we've had around 3,000 citizens who've died with or of COVID-19. The problem I have with this data, and I'm sure you'll agree, Robert, is that ascertainment bias right now in 2025 means that whilst this epidemiological data is helpful, it's perhaps not accurate because of the way we test, because of the way we code, because of the different importance different countries overlay on the COVID-19 pandemic. I think wherever you practice though, and I'm sure again you'll agree, Robert, it's not just death from COVID-19 which is impacting our global citizens, it's the impact that those citizens with their COVID-19 have on the rest of the healthcare we're trying to deliver. Let's take England, for example, Robert. Here we have around 100,000 acute and general medicine beds on any given day of the week. And if you look here to the number of patients admitted with COVID, what we're seeing here is somewhere between 1.5% and 3.5% of our hospital beds right now are occupied by patients with COVID-19, inhibiting the way in which we can manage our hip replacements, our knee replacements, our transplant surgeries, our oncological surgeries. So I think what the opportunities we need to grasp are is to try and avoid that admission of COVID-19 patients into these hospital beds where we have a valid alternative. But what I also think, Robert, is that as we in the Western Hemisphere, global North, we always think in terms of seasonality for respiratory viruses. We think about the winter season with the flu epidemics or the RSV chaos. And whilst it's easy to slip into that paradigm for COVID-19, I'm not sure we're there yet. What we're seeing is waves, but we're not seeing winter waves in isolation. Yes, we're seeing an increased number in winter, but for example, here in the UK, we also saw a summer wave.
Luke, I would completely agree with you on that. In fact, while we might will the virus to become a seasonal virus, it really is not so far. It is, however, an episodic and a consequential virus. So I think if we think about it as episodic rather than seasonal, that may help frame our discussion.
Couldn't agree more, Robert. So I alluded earlier to how here in 2025, COVID-19 has a differential impact on different elements of our society. And when we're thinking of COVID-19, I think of which cohorts of the citizens I serve are most at risk for progression towards severe disease with their COVID-19. Who is most likely to be hospitalized or to die from this? And the kind of risk factors I conceptualize with this, Robert, and feel free to disagree, are those of advancing age, those with chronic lung disease, cardiovascular disease or neurological disease, those with diabetes and those with immune suppression. I think different physicians, different epidemiologists will also factor in some other variables that may increase your likelihood of progression to severe disease. And by that, I'm thinking those perhaps who are in long-term care facilities, those who are not up to vaccinations. Any others you want to throw in there, Robert?
I would certainly say that patients with renal dysfunction, chronic kidney disease remain at high risk. And then pregnancy really alters the immune system. So both while pregnant and even in the year afterwards, I've seen patients that have previously had COVID have completely different responses once they're no longer pregnant. So I think the puerperium is certainly an area that changes things. So
we have episodic COVID waves, differentially affecting different cohorts within our society. We recognise the risk factors for who is at an increased risk of progression towards severe disease, but how can we manage this? And when we look across the globe at the different medications which are licensed and have an evidence base for pre-hospital treatment of patients with COVID-19, perhaps we come across a short list of maybe three. The first that springs to my mind is nirmatrelvir-ritonavir, which is indicated for pre-hospital treatment of patients with COVID-19 at an increased risk of progression towards severe disease, meaning hospitalization and death. It has to be given within 5 days of onset of symptoms, and depending upon where you practice, you might have slightly different inclusion and exclusion criteria, and this was underpinned by the phase 3 trial that was EPIC-HR. Then we have remdesivir, a parenteral therapy, which has to be given again within the first 3 to 5 days of onset of symptoms and was underpinned by the Pine Tree study.
And actually in the Pine Tree study, we used inclusion-exclusion criteria of up to 7 days.
So that increase in time to initiation of therapy, we might come back to actually, Robert, because that is one of the issues that is important when we try and operationalize instigation of these therapies.
And in fact, in our randomized clinical trials, we had to say, when did the symptoms start? In the real world, sometimes you have patients that have allergies. They have other symptoms that might confound and might make it difficult to place a precise time. And I think sometimes if you're uncertain and you might say, maybe this is 5 days, maybe this is 7 or 8 days. If you're not sure, sometimes you might want to take a very patient-centric approach. You don't have to be as rigid as you are in a randomized clinical trial.
Could not agree more, Robert. Then the third drug, which is licensed in some areas of the world, is molnupiravir. And molnupiravir's efficacy data was derived from the Move Out study. It is oral, is indicated within 5 days of symptom onset, and offers a third alternate in some areas of the world.
So we have, as you discussed, the randomized controlled trials that inform us in the early phases of the pandemic how antivirals worked. Now we actually can complement that with what we call the real-world evidence that provide us not efficacy data, but effectiveness data, which really informs us, does a therapy continue to work as the virus continues to evolve, and as our immune systems continue to change in response to that. So, Luke, would you like to walk us through the data that we have with ritonavir-boosted nirmatrelvir in real-world effectiveness data.
Thank you, Robert. And I think I'd just like to reiterate one of the points you made, because of course phase 3 trials focus in very constrained populations that really let us get a feel of how a drug works. What real-world evidence does is allow us to generalize that. And in that generalization, in that real-world evidence, what we often see across all of these peer-reviewed journals that we read, that we generate data for, is replicates, study replicates. And if you look out there towards real-world evidence of nirmatrelvir ritonavir, you will see a host of different manuscripts ready for you to consume. I just want to pick two of these that I think were done particularly well, that allow us to think about the effectiveness, as you said, as a different word to efficacy, about how these drugs work in the real world. The first was put out in Clinical Infectious Diseases and was derived from a large Israeli data set. Now, this had an inclusion criteria of citizens who were over 18 years of age, who had their first ever positive COVID-19 test in early 2022, but whom had a comorbidity that made them eligible for treatment with nirmatrelvir ritonavir. They were eligible irrespective of whether they were vaccinated or not. And of course, the efficacy studies, the EPIC-HR study for nirmatrelvir ritonavir was done, yes, in citizens with high risk, but was done in predominantly unvaccinated citizens. When you look at this Israeli data set, you can glean a few things. It, at its initial number, had 180,000 citizens, but actually only just under 5,000 of them received nirmatrelvir ritonavir. The other 175 did not, despite having a risk factor that meant they were eligible. When you look down the comorbidities that these study participants had, you can see how there is a slight preponderance amongst those who receive nirmatrelvir ritonavir for being more likely to have chronic liver disease, more likely to have chronic lung disease, more likely to have chronic kidney disease. And in fact, the only thing that was weighted more heavily towards those who did not receive nirmatrelvir ritonavir was obesity. When you then look at the outcome data, at the forest plot which demonstrates which cohorts within this parent population of 180,000 who perhaps had better outcomes with receipt of nirmatrelvir ritonavir, you can see three cohorts stand out. That of those patients with pre-existing cardiovascular disease, those with pre-existing neurological disease, and those with immunosuppression. But of course, immunosuppression, as you know, Robert, in your profession, is a heterogeneous group, and perhaps we might revisit that in a moment. The overall hazard ratio was about 0.54, but do look at that confidence interval there. It is quite wide. And I think we just need to take this as being a good example of a real-world study, but there are, of course, confounders and biases within there. I want to now leap from Israel over to North America to a US study. And this US study was based in Massachusetts, and it tried to replicate the inclusion and exclusion criteria of EPIC-HR, but in real-world populations. And they had a parent population cohort of around 45,000, so around 12,000 received nirmatrelvir ritonavir, just over 30,000 did not, and they matched these. And look here now to these adjusted risk ratios. So what we see in this real-world replicate, if you like, of EPIC-HR, where you're looking at the onward risk of hospitalization within 14 days or death within 28 days, we're seeing an adjusted risk ratio of almost half for the composite outcome measure there at 0.56, for hospitalization alone 0.6, but then draw your eye down to the bottom there, and you see the adjusted risk ratio there, Robert, of being about 0.29 for those who receive nirmatrelvir ritonavir in this high-risk population compared to not receiving nirmatrelvir.
Luke, I see those curves and they separate very early, and that really is a replicate of the RCT data, and it really dispels this notion of watchful waiting. In fact, I receive a lot of calls saying, I don't know what to do, I'm asymptomatic, I have no fever, I have no chills, I just have a sore throat, I just have a headache, I just have a cough, and I say, you can't be pregnant or not. You can't be partially pregnant. You either are or not. You are symptomatic. You just don't have a fever. Yeah. And in fact, the lack of a fever often is what dissuades someone to seek an early antiviral. And you see in this real-world evidence that if you have symptoms, you might as well seek therapy because those curves start separating early.
Agree. Completely agree. But nirmatrelvir ritonavir is only one of the 3 agents we think we have accessible to us. Robert, do you want to talk me through the real-world evidence for the other 2?
Absolutely. Thank you. So remdesivir was studied in the Pine Tree randomized controlled trial that I had the opportunity to participate in. And in fact, the Kaplan-Meier curves there really had the same shape and relative impact as the ritonavir-boosted nirmatrelvir and other early effective antivirals that were authorized or approved. And so we really have this tenet that the best time to use an antiviral for a respiratory virus is as early as feasible, as early as the patient presents. Remdesivir is unique because it actually spans the spectrum of COVID-19, that window isn't foreclosed even if a patient leads to hospitalization. So patients that are non-hospitalized with one or more risk factors are eligible for remdesivir, and patients who are already hospitalized with or for COVID-19 are also eligible for remdesivir. And we have the ACT-1 clinical trial, which was the first RCT that showed there was clinical benefit with decreased time to recovery in hospitalized patients. And we have the Pine Tree data that bookends that and says pre-hospital you have a benefit. So that leaves a gap in the middle of patients hospitalized but non-hypoxemic that are often subjected to this watchful waiting approach, which I would argue is not to the patient's benefit. In fact, we often talk about risk factors, and with risk factors, I would posit that if a patient is sick enough to be hospitalized for any reason, they must have a risk factor that the last thing they need is COVID-19 complicating that. So regardless of whether they happen to have incidental COVID-19, hospitalized with but not for COVID-19, or hospitalized for COVID-19, they warrant therapy. So in this real-world evidence, what we did is we looked at 1/4 of all U.S. hospitals, and we asked the question of patients hospitalized with COVID-19 as the primary diagnosis within the first 2 days of hospitalization, present on admission, were they treated or not treated with remdesivir? And we found that the patients treated with remdesivir had a lower risk of mortality. Now, this is something that you really can't drill down to in an RCT because patients that are non-hypoxemic are at lower risk of mortality. But you have patients with influenza, you still treat them because of other clinical benefits. We actually have this hardest of all clinical benefits, mortality data for non-hypoxemic patients now. This was really only accessible by using real-world evidence. And you see that this exists both in the overall pandemic as well as in the early stages, pre-Delta, in the Delta phase, and then endures even into the Omicron phase. So if a patient's hospitalized with or for COVID-19, they warrant an antiviral. We can also impute what patients' COVID-19 severity is to determine whether they should be treated. In other patients, we don't have the opportunity necessarily to treat them early because they haven't presented early. We have to meet them when they present. We have to educate them in advance to let us know, but unfortunately, hospitalizations continue to happen. And across the spectrum of COVID-19, from pre-hospital to hospital, and across the spectrum of hospitalized patients, non-hypoxemic to hypoxemic, we now have the data to say that remdesivir continues to offer benefit, and that includes patients even that have progressed to invasive mechanical ventilation or ECMO. Now, I don't have the exact answer for that, but this is real-world evidence on effectiveness. And patients might be hospitalized and on invasive mechanical ventilation for another reason. Maybe they had trauma. Maybe they're intubated, that you shouldn't deprive them of the ability to receive an antiviral. You shouldn't be so rigid. You should be patient-centric. And in fact, that's what the guidelines tend to recommend is what is the baseline oxygen support you'd expect, and then offering the treatment based on what their imputed severity of COVID-19 is. But In Act 1, we didn't have many patients on invasive mechanical ventilation and ECMO. This really provides effectiveness data to say, even those patients, it may be reasonable to still treat them. Now, the guidelines haven't caught up with that, but certainly the imputation of the clinical severity of COVID-19 is important. A patient population near and dear to my heart, no pun intended, as a transplant cardiologist, are the immunocompromised patients. So whether that's a solid organ transplant patient, or a hematopoietic stem cell transplant patient, a patient on a disease-modifying agent, perhaps a biologic for a rheumatologic condition or otherwise, those patients are uniquely susceptible to COVID-19 and may have prolonged replication of the virus. And so what we've also used real-world effectiveness data to show is that these immunocompromised patients, even in the Omicron era, continue to receive a benefit from remdesivir in the hospitalized setting. And that provides reassurance that to not delay therapy for our patients. And it's important to note these were patients treated with the first dose within the first 2 hospital days. It's difficult to get out of the emergency room without an antimicrobial, even if we know a patient has a viral disease. But sometimes there are structural barriers to getting an early use of an antiviral, and I think we need to overcome that. Lastly, after a patient is discharged, we want to keep them well. And so in this analysis, we looked at patients that were hospitalized and then discharged, and during that index hospitalization, did they receive or not receive remdesivir? Both in the overall population, the patients with advanced age, and the immunocompromised patients, all 3 of these cohorts continue to receive a benefit. And if someone is being rehospitalized, that means that they're still at risk. And so it really says that the early treatment index hospitalization is so critical not to take a watchful waiting approach. Lastly, Luke, you had mentioned molnupiravir. I would place molnupiravir into a different class. It's really a viral mutagen. In contrast to ritonavir-boosted nirmatrelvir and remdesivir that are traditional antivirals, molnupiravir acts in a different fashion. It's a degenerate-based prodrug, and it induces transition mutations so that the virus accumulates so many mutations that it can't continue to replicate by a mechanism called error catastrophe. And in this Nature paper, we really saw this borne out. In countries where molnupiravir was authorized or approved, we saw an increase in transition mutations and an accelerated viral evolution specific to those countries. And so in the guidelines, certainly the level of evidence, even in the RCT data, was much more marginal. And in the guidelines, it really, where it still may remain, it's at a lower level of evidence. It's an alternative if a patient either has a drug-drug interaction that's not manageable with ritonavir-boosted nirmatrelvir, or if they don't have access to remdesivir, and if a clinician feels that they warrant that. Certainly in my immunocompromised patients that already have a risk of prolonged shedding, prolonged replication, I don't want to do anything else that would promote viral evolution in those patients. So Luke, how would you integrate these data that we discussed into your clinical practice?
So I think what we've reflected on between us, Robert, is that COVID-19 is still with us, still causing mortality, still causing morbidity, still causing occupation of healthcare resources and beds and inhibiting the flow of patients who need other things doing for them. Now, what we've also reflected on is that the efficacy data for the 3 agents we have available to us, so nirmatrelvir, ritonavir, remdesivir, and molnupiravir, has been borne out to varying degrees in real-world evidence and has been replicated across different settings. But the key thing I have, Robert, is how are we going to implement that between us? Now, we focused on the fact that we understand across our entire profession what the risk factors are for higher risk for onward hospitalization and death. But how can we operationalize these treatments through into getting them into the patients we need? So how can we focus on the cohorts at highest risk, Robert?
Well, Luke, I think one of the ways to do that is to prepare them in advance, because they need to know that the therapy is available. And in my patients, I prepare them in advance. I live in a state where if you present to an emergency room, it's very easy to get things that are either less effective, potentially ineffective, and in my immunocompromised patients, potentially places them at increased risk. And those include corticosteroids. We know corticosteroids in the hospital setting for hypoxemic patients certainly save lives. However, in the pre-hospital setting, it seems to increase the risk of progression to admission. So I educate my patients, please don't get corticosteroids for COVID-19. If you're on them at baseline for other reasons, continue them by all means. But I don't use corticosteroids in the pre-hospital setting. Similarly, if they present to emergency room, they're often offered molnupiravir because it's the easiest option because the provider doesn't need to look at drug-drug interactions. And so for my patients, I educate them in advance. Certainly, molnupiravir is, the data is at best equivocal. And as I mentioned, it can promote viral evolution, viral mutagenesis. And so the highest level recommendation for all of the medications is ritonavir boosted nirmatrelvir because it is oral, it is effective, and it maintains effectiveness. However, clinicians might be apprehensive about using it, and so we need to educate them about the Liverpool drug-drug interaction checker. In fact, I go to the length of advising my patients in advance. When you get COVID, not if you get COVID, here is whether you are or not acceptable for ritonavir boosted nirmatrelvir. For most of my solid organ transplant patients, unfortunately, they have a relatively unmanageable drug-drug interaction because of tacrolimus or sirolimus immunosuppressants. And so unfortunately, they can't take the ritonavir component, and so that doesn't work. And so I have that cohort of patients for whom I recommend an operationalized IV remdesivir. I recognize that's not feasible in all areas of the world. However, for many of my other patients, they have cardiovascular disease, they're on a statin, they might be on an anticoagulant. Well, certainly the statins are incredibly easy to manage. Yes, there's a drug-drug interactions. The answer is hold it for 10 to 14 days. There's other ones with anticoagulants. Some of them, it's dose reduced by half for about 10 days. It's important to remember that ritonavir's effect, even though the dosing is only for 5 days, the effect can linger out to 10 or more. And so that adjustment. So managing anticipatory guidance of how to manage and using those resources like the Liverpool checker. Luke, what other lessons do you see in this?
So I very much agree, Robert, with the preemptive identification of at-risk patients and the preemptive pre-planning of how they're going to manage any potential drug-drug interactions and their access door to getting that prescription. The other thing I'd overlay on there, Robert, is the need to test. And of course, back in the peak of the pandemic, citizens themselves were in the zone of testing. Perhaps as we moved out into the post-pandemic period, patients have forgotten about test at home lateral flow assays. I think there's an opportunity in all of our outpatient routine appointments to not only do the drug-drug pre-planning you mentioned, Robert, but also to re-emphasize to our patients that early testing whenever they get a respiratory virus symptomatology is important because, as we've said, you have a limited handful of days from symptom onset through to initiation of therapy.
I think that leads to this point that, we know that time is important for many other diseases. If someone has an acute thrombotic stroke, we know that time is brain. If someone has an acute ST elevation myocardial infarction, we know that time is muscle. The best time to treat a respiratory virus is as early as feasible. We really have now gotten to the time of the pandemic that we can dispel this watchful waiting approach. There may have been good reasons early in the pandemic when there was a limited supply and you needed to maximize the benefit to the population, minimize the number needed to treat. Now you can really focus on your individual patient. Does your individual patient have a symptom and do they have a risk factor, and you can get them treated? We have the RCT data and we have the real world evidence effectiveness data, and we know that even in later stages in modern times in this post-pandemic era that the antivirals, when used, continue to work, but they need to be used.
So I think what we've heard here is that COVID-19 continues to evolve. It continues to impact ED presentations, hospitalization, bed occupancy, and mortality. But we also understand from the RCTs and real-world evidence that early treatment, even in heavily vaccinated populations, even in Omicron lineages, has been demonstrated through multiple replicate real-world studies to reduce hospitalization and to impact mortality. Yet the different antivirals we have within our repertoires differ in their utility in these different real-world evidence studies. And they differ in their adverse event profiles, and they differ in their operationalization. And that can be different wherever you practice. I think the different pre-hospital treatment options for COVID-19 therefore need to be titrated to our different service capacities, reflecting the needs of the different cohorts we serve. And you, Robert, serve cardiology transplant patients, but some of our listeners will reflect rheumatology cohorts, diabetology cohorts, and you need to think about what is practicable. Similarly, it is only through close collaborative working that we can maximize the impact of these antivirals and the pathways we put in place to access them for our different patient cohorts. And I know a little bit about virology, and you know a little bit about cardiology and the medications used there and the transplant medications that I can't even pronounce, Robert. So through collaborative interdisciplinary working, we can really try and advance care for this cohort of patients. With that, I have to bring this program to a close. Thank you, Robert.
Thank you, Luke.
It's been a real pleasure to discuss this with you, and thank you for participating in this activity. Please do continue on to answer the questions and to follow and complete the evaluation. Thank you and goodbye.
This program was presented by Medscape Education Global.